So this is another iteration of the concept of VIVA Unscripted, and our opportunity is to have a discussion with a couple of experts in the field and to really hone in on some of the next steps in the development of the field of carotid disease. I have with me Chris Metzger, who is from Wellmont, Tennessee, cardiologist, Peter Soukas you're in Rhode Island, correct?
Brown.
And also cardiology, and these guys are recognized leaders in the area of carotid revascularization. And what I wanted to focus in on first for the two of you guys is asymptomatic carotid disease. We know that there are a lot more asymptomatic than symptomatic patients, and the question is who to treat, how it should be done, that kind of thing. Chris, what do you think about asymptomatic carotid disease with better medical management? Is it going to go away, or is it going to continue to be a problem that we need to manage with repair?
So a couple things, Peter. First, we need to acknowledge up front couple things. It's relatively benign in the short term, asymptomatic carotid disease. That said, most strokes were asymptomatic up until the time they presented. So I think that some of the data presented, I don't agree with it. Meta-analysis, 50% carotid duplex. I don't think strokes have gone away from asymptomatic disease. So I think we have to individualize the risk-benefit ratio for every patient. If there's somebody 83 and they're calcified and they're asymptomatic, they probably ought to keep that 83% or that lesion. On the other hand, if they're younger and have an 80 or 90% lesion with favorable characteristics for intervention, and you're an experienced operator who has a proven low stroke rate, we know that carotid stenting or carotid endarterectomy are durable procedures and can be done at very low risk. So if you can take the risk away with a low risk procedure that's durable, I think it's very reasonable to intervene on tight asymptomatic disease with a carefulized risk-benefit ratio assessment.
Okay, so I asked you the easy question.
Thank you.
I'm going to ask you the hard one, and that is if your mom has a carotid stenosis and you're advising her about what needs to be repaired, tell us the degree of stenosis that you would say is significant, and tell us about what kind of therapy you would lean toward in which situations. I won't prescribe what her heart is doing in that, but...
Yeah. Obviously it needs to be an individualized decision, and there are a lot of factors to consider. One of the good things about the scaffold trial was that it forced all the operators to get CAT scans ahead of time. And so I think we got a much better appreciation for arch disease and the degree of calcification, tortuosity, because we know from clinical experience and clinical trials that those factors can increase the risk of stroke. And since the number is going to be pretty low, it's important to factor all of that into the decision-making process. So if a patient does not have critical calcific or type 3 arch, if the lesion itself is not horrifically calcified or ulcerated, and it looks like it would be, from a technical standpoint, a pretty straightforward case, and if it's a critical lesion, as Chris mentioned, greater than 80%, those are patients that I still, to this day, recommend that they be treated. So I think the alternative imaging is very helpful to me in terms of risk stratifying them before they actually make it to the lab.
That makes sense. So do you envision, Peter, a time when we have a test, MRA or something else, that helps us understand on a more granular level how risky the plaque is? And that's been the focus in cardiology, is finding the vulnerable ones.
Right, yeah.
How will we find the vulnerable ones in carotid disease?
Well, there is some data with obviously grayscale imaging, but MR really seems to be the most promising technology. I mean, we know that Dr. Fuster's groundbreaking work for over a decade now, looking at sort of hot plaques with MR. I suspect that we'll probably see a continued expansion of that technology to help us risk stratify patients. And those would be the kinds of things that we'll be looking at to help us treat an individual patient with all those other variables that we just talked about.
Yeah. So now you get the hard question. Okay.
Bring it on.
You're king of the universe. You have a magic wand that allows you to change the national coverage decision for carotid stenting. How would you change it in a way that makes it safe and acceptable and gets the right therapy to the right patient?
All right, so I'm going to break up my wand right here. No, here's what I would do. I think this is important. I think it needs to be covered. But the reason appropriately that they're reluctant to, in my opinion, is they it's never been controlled. We don't control ourselves very well in medicine. So how I would do it is I would couple reimbursement to performance and experience. So I think you have to set the bar high for who can do the procedure, okay? They have to participate in ongoing adjudicated registries. And if you coupled reimbursement for carotid stenting to appropriate patients and high volume experienced operators who then perform in prospective registries, that's how I would keep it away. If you keep it to the local hospital saying who can do it, who can't do it, they can't afford to open the floodgates. I think that's why they've been reluctant to cover carotid stenting.
So you're saying trust but verify.
I want verification. I think you get a carotid stent card that you have to earn, and then you have to keep that card, you have to go through ongoing surveillance.
Who's the right group to adjudicate that? Would that be, you mentioned registry, so this would be something maybe sponsored by a society, or?
I think the societies have to come together and decide what the standards are. And yes, I think there should be standards, and I think that everybody has to be reported. So, your results have to be all inclusive and adjudicated.
One place to start would potentially be with things like VQI, for example. So our site is a member of VQI, and then we have all of that data that's internally reviewed as well. So it's peer-to-peer, but it's also reviewed at a hospital administrator level as well. And there are criteria based on performance in terms of who gets to do it and who gets to keep doing it.
That's a great point and a real-world example. I like that. So let's talk about symptomatic disease just for a minute. So with regards to symptomatic disease, there's a lot of discussion about the timing of therapy. And we know that patients who've had symptoms are at high risk for recurrent symptoms early on after the event. And yet with carotid stenting, the highest risk is with carotid stent for a hot lesion, if you will, one that's recently symptomatic. So does that change the balance for you about who should get a carotid stent versus who should consider going for some other therapy, for endarterectomy or for transcervical, something like that? What do you think?
So I think you're right. These are the highest risk patients in every aspect. If they don't have a neurologic residual deficit or a big MRI hit, you want to intervene early because they're at high risk for another stroke if you don't do anything. Then the question is, what do you do? We still do a lot of carotid stenting in appropriate patients, but realizing these are hotter lesions, you're going to escalate to either TCAR, proximal protection, consideration of 2 stents or a micromesh stent, those kind of things. I would have a lower threshold, however, to say that surgery may be better if they have a really hot lesion, if they were appropriate candidate for surgery.
How about for you, Peter?
I think I follow a similar strategy. We know that dual antiplatelet therapy can sort of help passivate that plaque and make it a little bit sort of cooler, if you will. So intensive antiplatelet therapy, in addition to everything that Chris mentioned, and again, if they've completely resolved and not had any recurrences, then if we can, we'll try to give them those precious 2 weeks that really seems to be that window of opportunity where you can lower the risk if you can just get them through that first couple of weeks. And then we would definitely, in those cases, also try to use proximal protection. We might even use distal protection, like in the case that I showed. And I think that those can, and using a closed cell design until the micromesh stents become commercially available. So all of those things, 2 embolic protection devices, dual antiplatelet therapy, proximal protection, along with a micromesh stent is probably going to be the way that we'll tackle those patients in the future.
So the 2-week Darwinian stress test, if they make it through there, then they're going to be lower risk for intervention.
So let's talk about that just very briefly. If you are seeing patients in the office on a regular day, and a patient comes to see you and they had a TIA yesterday, what's your urgency?
Depends on if it's a little amaurosis or if it's a real hot symptom. I think if it's a hot symptom, there is urgency, and so you're going to decide which kind of revascularization are there a candidate. But I believe there is urgency because they've already declared themselves at risk for stroke, and you can't predict that. You have a therapy that can help them. I think it's early. In fact, I had that scenario last week on a Wednesday and performed this procedure on Thursday.
Okay, so
Yeah, and sometimes if you're concerned it's other than just a little amaurosis, I mean, those are patients who I think legitimately you should probably consider admitting to the hospital, putting them on heparin, dual antiplatelet therapy, and really trying to quickly stabilize that plaque.
Yeah. Do you think it's important, Peter, as a cardiologist, what's your sense about when you see a new patient with carotid disease, how important is it for the patient to be on statins and antiplatelet agents? And if they're symptomatic, maybe dual antiplatelet agents right off the bat.
Well, we do have some data in that regard. The Sparkle trial was published a number of years ago, which showed that high-intensity statin therapy can be helpful in terms of actual prevention of stroke. So I think high-intensity statin therapy, and I mean, these are unstable plaques. Whether it's an unstable plaque in the brain or an unstable plaque in the heart, they need very aggressive antiplatelet therapy. So we will go to the wall with medical therapy, ACE inhibitors, aspirin, Plavix, and then just really try to get them maximally treated before they actually either go to the OR or come to the angiographic suite.
So let me just get a sense from both of you about if you could project yourself 10 years into the future. So 2027, the practice of carotid disease management, what's it going to look like?
Boy.
That's a hard one, isn't it?
I think all patients, regardless of whatever you choose, are going to be on maximized medical therapy. So your question, they're all going to get statin, some form of antiplatelet therapy, and close follow-up and risk factor modification, period. And then I think it's still going to be individualized. The question remains, who will be reimbursed or not? And can we ever get to the point where we make a decision based on our judgment, individualized the patient, or are we still governed by old rules of who can get reimbursed? I still think that revascularization will be an important part for 80+% and for symptomatic patients.
I mean, my hope and expectation would be that a lot of these things that we talked about earlier, such as risk stratification based on plaque morphology, so whether it ends up being MR or some other imaging modality to help guide us in terms of risk stratifying an individual patient to decide, are they going to be medical therapy, are they going to be an endoendorectomy, are they going to be a stent? Obviously, dual antiplatelet therapy, high-intensity maximal medical therapy, and I think micromesh stents and a much higher use of TCAR probably all reliably, I think we can predict will be more the norm 10 years from now.
Yeah. Do you think we'll finally have solved the understanding of what the long-term risk of an asymptomatic lesion is based on, well, let me just preface that a little bit more by saying that if you just go get the newspaper or you go pull a journal, you might find an article that says the risk is so close to zero. Why does the patient even come to the office when they've had a tight stenosis? But if you look in the scientific literature, and I'm sure you guys know this, but for everyone, what you find is that those patients have actually never been studied. A real cohort of patients with real lesions and high PSVs and actual dangerous morphology have never been followed long-term, whereas there are lots and lots of studies following patients with moderate lesions where the symptom rate was low, and that's sort of been interpreted. So, I mean, what's the study that we got 10 years, I gave you till 2027. What's the study you're going to do to really try to understand this?
Yeah, CREST-2 will hopefully shed a little bit of data in that regard, but I'm not terribly optimistic that it's going to be the end-all and be-all because it's a pretty restrictive protocol. As Chris pointed out earlier, like that Ann Abbott paper that neurologists love to quote. I mean, there's a lot of holes in that data.
Huge.
And I think we have to really be honest and upfront that there are a lot of methodological flaws with that analysis. And the other paper from Marquardt was also another one that's quoted very often. And we have to just be honest and say that the flaws in the analysis was really not apropos to the practice of carotid intervention in 2017.
It's going to be interesting because if we believe that asymptomatic carotid disease shouldn't be treated, then they're going to have to stop reimburse carotid duplex. Why would you do a carotid duplex if you can't treat it in an asymptomatic patient? Some of the neurologists who don't like intervention still do bi-yearly carotid duplex. So I think we have to find out, Peter, in true 80%, what's that natural history And how you're going to do that, I don't know. That's going to be a challenge. Who is going to say, sure, I'll volunteer for that study. I don't want it fixed. You just study me to see how
Well, I think
natural it is.
this is part of the problem with the studies we have to date, and that is the patients that we have the impression need fixing get fixed, and the ones we don't think need to be fixed get followed for natural history. So we really don't know
Just like
what the
coral
risk
and
of
renals.
asymptomatic. Yeah. Anyways, I'm going to call it to a close there. Thank you very much, Peter and Chris. That was
Thank you.
excellent.
Thank
Very
you.
Thank you, Peter.
informative.
Thanks.
Thank you all.
Excellent.